Hello, everybody. Good, thanks, Amelia. Hello, everybody. We're just gonna go ahead and get started, get some tech things set up, and then we'll open up our webinar. Mahalo for those who have jumped on and joining us today on this Aloha Friday. I'm gonna like a minute or two more so for others to jump on. Great. Actually, let's go ahead and get started. Hello, everybody. Welcome to today's webinar on Building Futures, AI in Healthcare, Tech Equity, and Workforce Development, presented by Chrissy Waianae, Director of Tech Equity from Waianae West Coast Comprehensive Health Center. Thank you for joining us. Next slide, please. Awesome. I just want to give a shout out to our organizers of this training, myself, Melia, who are both from Hawaii Public Health Institute, as well as the Hawaii Public Health Training Hui Steering Committee members. Next slide, please. We want to thank our sponsors and partners for providing today's training, which include the National Association of Social Workers, the Hawaii chapter, the State of Hawaii's Department of Health, Alcohol, and Drug Abuse Division, as well as the Western Region Public Health Training Center. Next slide. Oh, and our other sponsors, I apologize. Again, Western Region Public Health Training Center, the Joint Accreditation Council, as well as the Public Health Learning Network. Next slide, please. Continuing education credits that are being provided for today for attending. We are offering credits for CHES, registered dietitians, licensed social workers. Next slide, please. As well as substance abuse counselors, prevention specialists, as nursing. So for attending today and completing our evaluation, you will receive 1.5 hours of credit hours. And to request your continuing education credits, please complete the evaluation survey by December 13th. The surveys will be distributed via Mahalo emails following this training today. Your emails will be coming from Melia. So if you do not, and if you are calling in today via phone, please make sure to email Melia, MELIA at hifi.org with your name and phone number that you use to call in today so we can ensure that you receive a Mahalo email. And certificates will be mailed out by the end of the month. And if you are missing your certificates by early January 2025, please email Melia for an update. Next slide, please. Some Zoom housekeeping for today. All folks, you are muted upon entry. For any questions that you have for Chrissy throughout the presentation, please drop them in the chat box or Q&A at the bottom of your screen. We will be taking questions in real time. So if something kind of pops up in your brain and you want to ask Chrissy in that moment, please drop it in the chat and Q&A and we'll make sure to pass it along to her. And this meeting is being recorded and will be shared on the Hawaii Public Health Training Hui's YouTube channel. And that link will be sent in your Mahalo email shortly after this training, along with the slides from today's presentation. Next slide. And I will hand it on over to Melia, who will introduce our guest speaker to you all.
Hi, everyone. My name is Melia. I just want to take the time to introduce our speaker. Chrissy Kuahine has over 34 years of experience at Waianae Coast Comprehensive Health Center, where she began as a registered medical assistant before transitioning to health information technology and specializing in electronic health records. As Director of Tech Equity, Chrissy leads initiatives to bridge the digital divide and improve access to technology-driven healthcare solutions. Her leadership in telehealth and digital literacy earned WCCHC the 2024 Tequity in Action Award from the American Medical Association. Chrissy holds a Master of Information Systems and is currently pursuing a Master's in Public Health to further contribute to improving healthcare delivery and equity. That's all for us. Chrissy, please take it away.
All right, well, aloha kako. I'm going to go ahead and share my screen. All right. Well, aloha again, and maka Melia, thank you so much for having me today. I am super excited to share what we're doing out here on the Waianae Coast on the island of Oahu in the state of Hawaii. And so mahalo again for that introduction. And as you can see there, top right of my introduction slide is our Tequity in Action Award. And we're really feel honored to have been recognized by the American Medical Association, as well as the Health Foundation, Tequity for a Health Coalition, in our work that we've done around digital inclusion. And for those that don't know what digital inclusion, maybe that's the first time you're hearing that term, that really encompasses the ability for someone to access the internet, use it because they know how to use it. So that's digital literacy, and then use it in a meaningful way. And we're going to talk more about digital inclusion and what that all, what elements or factors that are incorporated into that. And again, I work at the Waianae Coast Comprehensive Health Center. March will be 35 years. I guess it's time flies when you're having fun and doing things that you love. So before I go into what we're going to be talking about today in terms of AI and its impact on healthcare, what I've been getting a lot of questions on is my new title. And so I've just been recently given the title of Director of Tech Equity. So it's pretty new, and it really was developed or came about through the COVID pandemic. So prior to that, I was director of EHR and then director of clinical and patient informatics. So besides EHR, I was really working a lot with more data, more reporting, and obviously more analysis. But what we found in our community in capturing our data throughout COVID is that the digital divide that our patients and our community are experiencing here are really a lot wider than I think we all thought. I think at some point before COVID, the thinking that we'd transition over to telehealth, which for our health organization, we're actually thinking about it in 2019. And so lucky for us, before the pandemic, we had already selected a telehealth vendor. We had the licenses in place. And like any other new technology, we had a regular implementation plan that we had scheduled. And then March 2020 came around, and us, like everyone else in the world, had to, transition to a more digital world. And so that's when we realized that we really needed to start to focus on how leveraging technology truly impacts our community. And so my focus is on digital inclusion. And again, that's making sure that everyone, our patients and our community, can really benefit from the technology that we're introducing, as well as innovation like AI that's evolving so much quicker than I think even anyone had expected. The other things that that I like to focus on is making sure that I work with community stakeholders. Of course, my organization, my executive leadership, our staff, making sure that the importance of digital inclusion, and as well as making sure that our staff and providers are trained up so that they can also work with patients when it comes not only to telehealth, but remote patient monitoring. And then even as you'll see in some of my upcoming slide, how we're using AI technology in the clinics. And so that really is a real shift in how everyone is working. So not only on the patient side, but really on our providers and our staff. And then I think really there has to be focus and attention and priority given at the policy level. And so what you're seeing here in terms of the pictures, I was able to attend a meeting in Washington at the White House with the Domestic Policy Council and Office of National Control Policy with a nonprofit research institute called Center for Telehealth and eHealth Law. And this was earlier this year. And my point was advocating for federally qualified community health centers, and that's what Waianae is, and talking about either making permanent the current telehealth waivers, or at least extending those telehealth waivers when it comes to geographic location, when it comes to, in the case of the National Drug Control Policy, which I think they've now extended it at least one more year till next year, being able to prescribe controlled substances via telehealth. And so, as we all know, especially in healthcare, at the policy level, that's where it's really going to drive how we can care for our patients, how we can improve access to healthcare, and of course, the reimbursement portion of it. And so that's where really my focus is going now this year, and so I'm really excited about it. So Waianae Coast Comprehensive Health Center, where we are and what we do. So as I mentioned, we're on the island of Oahu, so and on the West Coast. And I like to look I like to show this map because the black line represents a highway that you come right into our community. And I don't know if you can see very clearly, but all the different satellite locations that we have along that West Coast, as well as clinics in all of our schools. So we have school-based health clinics in our intermediate and high schools along the coast. What's not showing here too, if you see the dot that says EVA, we also have a EVA clinic and a Waipahu and a Kapolei. So we actually have 3 more satellite clinics on the leeward side of the island. But getting back to that black line, if you notice, it doesn't go all the way around the island. So if I don't know if folks are familiar with Oahu, but we don't have a road that goes all the way around. And why I like to always point that out is where our main service area is located in Waianae, we only have one way in and one way out. So although we are not considered rural anymore, because we have over 50,000 in terms of population, we definitely have some unique challenges. So definitely geographic. I mean, we can have an accident and the road is shut down. And that just happened about 3 weeks ago, and the road was shut down in and out. And so lucky for us, our health center, although we started with just one building, you can see in 1972, we're now on the right-hand side. We have multiple buildings, and we also have a 24-hour emergency room. And so when you talk about really safety net provider, especially during disaster emergency situations, we are the only healthcare provider for our community. So if you look at our UDS numbers, and this was from last year, so the amount of unique patients that we saw, I think that what's telling me is, well, definitely our telehealth visits, and that encompasses our medical care as well as behavioral health. And then if you see the majority of our patients are of Native Hawaiian descent. So if you think about those other unique challenges in terms of cultural and historic oppression that happened with our Native Hawaiian population. And then what I don't have here on the screen is really our demographics. So it's in terms of socioeconomic data. For our patient population, over 71% live at or below the federal poverty level. 60% of our patients receive some kind of subsidized healthcare, so that would be Medicaid. Our dual is about 10% Medicare and a dual eligible. If you think about chronic condition, I think this is really telling. And so when we talk about really wanting to make sure that we focus on improving, not only improving access to healthcare, but creating ways that our community can access it that is right for them, right, to bring healthcare to where they're at. Our obesity numbers for our community is almost double that of our state, and it's definitely double that of Honolulu County. So we're at 46%. Our diabetes prevalence is 16.3 compared to our state, which is 10.9. So setting the stage for AI in public health, as well as digital inclusion or tech equity, to make sure that the technologies as health organizations, we love at the NAC level, they talk about Innovation X, right? So having, looking towards innovation that's going to help with value and efficiency. But as a health organization, everything bright and shiny may not always be a good fit for your community. And so that's something actually in my role that I'm always cognizant about, to make sure that it meets our community needs and that it's culturally appropriate. And so what we're going to cover today is how AI is transforming healthcare, and that can be, you'll see what we're using it for in terms of advanced data analytics and identifying our high-risk patients, and then enabling ways that we can make sure that we offer interventions that have the best healthcare outcomes as well as cost savings. And then with digital inclusion, like I said, we want to make sure that leveraging technology it's not going to widen the gap, right? Because it could do one of two things. It can either benefit the folks that we're trying to serve, or if we're not cognizant, if we're not watching out for how that people are able to access that technology, it can actually widen the gap. And so we're going to go over those three things, and then talk about what we're doing at Waianae Comprehensive, again, with analytics, as well as some AI technology, ambient technology that we're already using in our clinics. So let's dive right in. And again, as Maka said, if you have any questions, please throw them in the chat. And if it's something they're going to monitor, and if it's something that we think, we want to answer now or have a little bit of a discussion, I'm totally fine with that, super flexible. Okay, so before we can talk about AI, about technology, I always start off all my presentations with digital inclusion. And this includes when I talk at our community summits, our community, looking at priorities that our community members are identifying. One of the priority areas in our last summit, and I don't know if you recall in the picture that I showed earlier, I had this slide up during our summit because one of the priorities was digital equity. It's not lost in our community that technology is moving so fast that you hear about folks working from home all the time. And those are not the same opportunities that a majority of our population are experiencing or even know about. And so why I like to bring this up is if you know nothing about social determinants of health, you don't know that terminology, which a lot of my community doesn't, but they are aware if you break it out into the elements or factors that contribute, right, to a patient's overall well-being, it's going to be all these things, right? Your food, whether you have food security, food insecurity, your education level, your access to healthcare, your physical environment. So, and then your work, your job, or your opportunities when it comes to workforce development. So this, when you look at this illustration, what I think is so impactful, if you really think about what COVID has done in terms of being able to access these essential services, these elements that contribute to everyone's well-being, it really makes technology, digital inclusion, a super social determinants of health. I don't know about everyone's state, but at least in Hawaii during COVID, a lot of the, so besides medical care, moving to telehealth, a lot of the essential services, right? So being able to, unemployment, being able to apply for medical insurance or resources to assist with paying your utility bills or rent, that all went online. And at least for our state, I think they've come to realize that it actually saves them money to have folks work from home. And so those things that went online very quickly during COVID, many of them have stayed exclusively online. And so I don't think there's, too much argument when it comes to saying that, hey, listen, digital inclusion, digital access, that really is a super social determinants of health. And so again, why does that matter? Well, it's about access and about equitable access so that everyone, regardless of your social status, regardless of your zip code, can all participate in our current digital world. It's not something that's coming in, the next 2 or 3, 4 or 5 years. It's already here. And so this is where I speak at community meetings, people will take a picture, and then this is what you have in your mind. I mean, for food insecurity, we have lots of food programs. In order to know where those food distribution programs, we put it out online, and to sign up for it, we have a QR code online. All of those things, quite honestly, QR code are very foreign. So now you throw AI in the mix. And I don't know about your community, but for my community, anytime we start talking about AI, there's this, they start envisioning the Terminator, coming in, taking over people's jobs, houses, and lives. And so this is where it is really all of our responsibility in the healthcare industry. And as you start to learn more, or if you're already using AI in your capacity, you need to start educating your staff, your patients, so that it's not a scary thing. We want to be able to make decisions around how AI is not only used in your organization, but really in your community. And so this brings us to really kind of just, I think, an easy way from an organization perspective, how AI, advanced analytics, can really help to use the data that hopefully you've all collected over the years to really be meaningful in terms of how, whether it's from a business perspective, and then of course, how that trickles down and how you can really make an impactful, meaningful decisions on how, for patient outcomes, and then also from a business side, how you can use that for negotiation power when it comes to working with your insurance plans. And so I'm going to just, before I start on the, the different levels of analytics, I will say for Waianae Comprehensive Health Center, we have an amazing CEO that has such great foresight and is such a visionary that if we've been using our EHR since 2000, and even prior to that, we had looked at all of our enabling services, enabling care services. So for maybe those that are not familiar with the term enabling care services, or maybe if you use some other terminology, those are those wraparound services or services that we offer to our patients that are not typically covered by any kind of insurance plan, right? So you're not reimbursed for it. But we know as healthcare providers, they contribute to our patients' outcomes, right? And so improving them, being able to help them navigate really for a lot of times, a referral to a specialist can be really difficult for a patient to navigate to make sure they actually get to that specialist. So the time that your staff, your patient assistance services, or your support staff are helping your patients with that, we have a code for it. And so they're all codified. And if you think about what a CPT code looks like, so we've codified all of our services. And this started, gosh, maybe 30 years ago. And so all of those codes we've had in our data bank. Now, mind you, 30 years ago, we didn't have this, AI as a tool. But again, as our CEO knew that data would be gold. I mean, there would be value there, and you could use it not only for analytics, but again, for, whether it's negotiation power. And then fast forward to 2000, we have our EHR. So think about that data. And then we were one of the first organizations to, through a grant, worked on creating the Prepare tool, so the social determinants of health survey. And so we have, needless to say, a wealth of data. So just about maybe 3 or 4 years ago, we started working with the companies here on the slide here, Foresight Health Solutions. So we've actually been using AI advanced analytics now for, gosh, maybe 3, 4 years. The 4 levels, if you think, and I think descriptive analytics, I think everyone's kind of familiar with that. That just summarizes all of those HQMs, health trends that you've collected over the years in seeing your patients. As far as diagnostic analytics, it'll give you all the information you need as to why you have this, diabetes prevalence or why you have this chronic condition. And then the predictive analytics, I mean, this is where you can do some forecasting, right, on based on particular risk scores, right, that are assigned to your patients. And all of our payers, I think, as you know, they already do this. They specifically, though, focus on one factor, and that's going to be those HCC risk numbers, right, that are assigned to HCC diagnostic codes. And so that's how they determine what, by patient, which patient will have, may develop a chronic condition, thus may have more impact in terms of cost to a plan. Well, I think really the gold, right, or the goal should be that prescriptive analytics, right? So once you identify your patients who are at most risk, wouldn't it be great if you knew exactly what interventions, right, what preventive care or personalized interventions that you could apply that would have the most impact, right, on your patient, whether that's patient engagement, and then of course their healthcare outcome, and then overall what the impact would, what kind of impact that would mean in terms of public health for your community. So having said that, we've been able to use our AI advanced analytics in doing just that. And so I think the easiest way to look at this is if we start off with the left-hand side, and if you think about what I just mentioned and how payers determine risk, right, for the patients that, so for us, our payers, for our Medicaid patients, they either can choose a particular plan. If they don't choose, then they're automatically assigned. What we found through our own exploration is that not all of those patients who are assigned to us, number one, some of them don't live in our community. Some of them may not want to ever choose a primary care provider or come to see us, but they may have a condition like cancer that is not something that we can help to improve. And so their risk score is very high, right? And so what we wanted to try to focus on is not only those folks that are at high risk, but really those folks that we can make the biggest impact. And so we have an impactability score. Now, mind you, don't look it up in the dictionary. I think we made up the word impactability, but we also have an impactability score, which comes about from our advanced analytics. And so what that encompasses is unlike payers who just look at one form of risk, which is the HCC risk levels, our analytics takes into account a patient's medical diagnosis, all their social factors, so those social determinants of health. We were able to work with all of our payers to receive claims data monthly. So we have that, as well as all of our EHR data, including all of our documents, so all of our narrative notes. And then we'll talk about how we use NLP, which is not necessarily AI, but being able to pull that information into the analytics where the AI can now take, gosh, I think probably over 30 potential elements that can contribute to a patient's risk. So if we look on the left-hand side to the medical risk factors, right? So if we just look at medical risk, and we can see if we pick out depression and bipolar, and I hope you can see that on the screen pretty close, but so depression and bipolar affect the most patients, so 407, so that's going to be at the top left, and their risk of adverse health outcomes is relatively high. But if you look at patients who are fewer that have been diagnosed with schizophrenia, their risk is actually higher, right? So if you look at how we determine risk by score. So you can think about it this way, right? Someone with schizophrenia then is 60% more likely to face complications than someone without that condition. So when you start thinking about assigning a precise risk identification, that's how you want to start to think about it, right? So it's not necessarily just their particular condition. So now we think about social factors, which, social determinants of health, again, is something we've been looking at for quite a few years. I think it may be new for other health organizations or even hospitals or even payers for that matter. And so, if we look at that, which is right below, S2H risk contributors, unemployment is the most common issue. And again, these are for our patients, 1,148 individuals. But transportation issues, right? So if they don't have a way to seek medical care or essential services, they're actually at higher risk. So our patients who are struggling with transportation issues are nearly 30% more likely to miss their appointments and have worse healthcare outcomes. So all of these things look at how both medical and social factors together then impact a patient's outcomes. And so that really does give you not only a clearer picture, but really a true comprehensive picture. And you can then translate that or present that to your payers in a way that is true and comprehensive, gives a true picture of the complexity of the patients that you're serving. And so that's one of the things as a community health center that we really had to put the accountability on us to figure out a way to prove that the patients that we are seeing are truly that complex. And what you're seeing on the right-hand side, I think, is very cool. We use NLP as well for our provider notes, as well as our community health worker notes. So if you have community health workers, case managers, you'll probably know that a lot of their note is not going to be really data discrete fields. A lot of it is narrative, right? Because each of their patients have different, very unique stories and challenges. And so that's usually documented in a narrative form. And what we found was pretty surprising. So if you look at what you're seeing here is the survey data. When I say survey, that means the social determinants of health or prepare survey. I will like to say here that we've actually modified our prepare survey so that it aligns better with our culture and our community. And so we're probably like, I don't know, on version 9 of ours, but it still encompasses the national survey components, but it's presented in a way that's more culturally competent and fits better with being able to get more, I'm going to say, more truthful or responses that are more representative of what our community is facing. Now, having said that, if you look at what the green represents, those are narrative notes. So if we just look at homelessness, from the survey, we were able to determine 233 people responded to this S2H survey that they had were either homeless or had some kind of housing, were in a housing crisis or housing issue, right? But if we looked and combed through all the narrative notes, we found that they're actually triple the amount of people that were facing housing issues. And that really, I think, became more enhanced and noted during COVID, because we had found that quite a few of our patients and community members who had never experienced homelessness, who had never experienced food insecurity until then, were finding it difficult to share their particular experience in a survey, right? What they're experiencing then. And so that's where those narrative notes became super important. And so again, thinking about AI, thinking about NLP, thinking about leveraging tools or analytics that may already be available. NLP is not a new technology, but maybe something that maybe is underrated or overlooked at this point, but something that certainly has helped us to really even better visualize the need in our community.
Chrissy, we had a question
Yes.
come in. What
Yeah.
influenced you to choose those diseases for your advanced analytics?
Actually, this is just a cut of an example. So we look at all the chronic conditions. We look at all chronic conditions that are entered into our patient's EHR and that we get from our claims data.
Okay.
So yeah, so what you see on here, that isn't, it's not limited. We look at all of, and the great thing we're also using about AI, because that's a really great question, is we just started to use AI for a pre-visit summary. And what we've been able to do in our EHR with the AI analytics is to go back, and this is really important for patients. If you think we've been using our EHR for 24 years. So for patients who have been with us for that much longer, if you think about the amount of data, right, that's in their EHR, and you can have AI, have AI comb through all that data and bring to the surface some of those conditions that may be contributing to their current condition, but have not been addressed in the last 2 years, 3 years, 4 years, 5 years. A great example, you have a diabetes patient, amputee, who, the amputation happened 3 years ago, but so, there's no complication with it. They're fine. They come to see their primary care provider, who then looks at their hemoglobin. So, all their codes, their diagnostic codes, look at diabetes, hypertension, whatever else they have, but there's nothing about the amputation. So, making sure that that amputation, because we know it still contributes to, can be barriers to transportation, mobility, that has to be included. And so that comes up to the surface for our providers to remember and recognize.
Awesome. Mahalo for answering that.
Oh, for sure. Yes. So in this next slide, when we talk about our prescriptive analytics, so remember when we looked at those 4 different levels of analytics, and I said, really where the gold is, where, the gold and goal is in that prescriptive analytics, right? So you can identify your patients at high risk, what contributes. And then we also, which I didn't have in a slide, is really we do have an impactability score. And how we determine that score for each patient is in our EHR, we set up a template that captures interaction between the community health worker, caseworker, when they try to contact patients. And we contact patients, especially those depending on whether or not they've come out of the hospital, depending on their condition status, their risk factor, and then if they've had a telehealth visit. And so that communication management template can track whether or not the patient was contacted, whether or not they've been scheduled, what their response was. And so that and also how many visits they've had with their providers. So imagine all this data that can contribute to an impactability score. And then that's how we really, again, can focus on those patients who we know that now with this slide, seeing the kinds of interventions that will have the most impact on their healthcare outcomes, we can have really a targeted type of plan for each patient. And so for this AI tool, there's a dashboard that comes up that looks very similar to this, but on each individual patient that our case managers use. And they're able to see now, instead of casting this wide net on all these different services that maybe we think that our patients need, we can really look and see which service has the most impact, right? So I talked about those enabling care services. And again, this is not an all-inclusive list. We have, gosh, over 200 enabling care services codes. And so really these are the ones that kind of, I think, resonate with everyone, right? Transportation, crisis intervention, follow-up monitoring, of course, advocating. And so how does the AI evaluate these services? Well, it looks at clinical data, demographics, those SDOH, all those risk scores, and it's able to predict then at that point which patients will benefit. So that's that impactability. And then looking at the data that we've already collected for each of those patients, right, and their utilization for transportation, if they've had to have medication management services, and then look at their health outcomes, look at how they're progressing. So now that's not something, if you think about all that data that is being used to come up with these results, you just, I don't see how you could do it without AI. So, I mean, really, when you talk about having an advantage, right? So if, for example, we look at transportation assistance, it says it's, based on what we've been able to determine is that it saves nearly a little over $900 per person annually by ensuring that patients can get to their appointments. I mean, that's almost a given, but to actually see a number, right? The amount of savings that's attached to that particular service is way more meaningful, right? When you are in negotiation with a payer, when you're talking about how AI is really impacting how healthcare is being, the system and impact of healthcare, right? If we look at follow-up monitoring, we had over 2,700 so patients, and it showed a savings of $351 per person annually. And that was helping patients manage chronic conditions and avoiding complications. And so this is where that prescriptive analytics, if you think about the benefit in so many ways, right? So your folks that are the ones who are providing the service and not having to walk blindly into how they can help their patient in the best way possible with the best outcome. And then from a payer perspective, we're all looking for ways that we can make healthcare more efficient, make it more valuable, more.
Chrissy, I'm sorry, can I just jump in with some questions?
Sure. Yeah.
Few that are related. So what EHR company do you use? Have you ever changed your EHR company? And will you lose data from years back with changing it? And has that ever been a challenge for you?
Oh, that is such a timely question. Whoever asked that question, do you know what's happening with SNO? Because so we've been using NextGen since 2000. So NextGen Healthcare Solutions. If anyone's familiar with NextGen, when we first bought NextGen, they didn't have a whole lot of suites. I mean, they're made most of their clients are community health centers, but when we purchased NextGen, they didn't have a lot of suites. And when I talk about that, they didn't have a behavioral health suite. They didn't have a community health worker suite of templates is what I'm referring to. So, and we have, as I mentioned earlier, we have an emergency room. So, and I think we're maybe 2 or 3 in the nation that have a connected ER from a federally qualified community health center standpoint. So they certainly did not have any ER templates. So if you can imagine over the, almost 24 years that we've been using it, we have, I want to say, over 500 customized templates, and that doesn't even include any of the, extensions, the pop-ups that come with it. So that's the EMR that we're currently using. We just recently signed a contract to migrate over to Ocean Epic. It's an Epic World. If anybody out there is using Epic, you know that that is their slogan. It's Epic World. So we are looking to start that process or that project in January 2025 with probably 18 to 20 month implementation or planning and moving over, workflow development, and then with a go live probably at about the 20 month period. Will we lose any data? That is actually what we're going to be working on in the next year is, how do we move all of our custom templates that can now capture data that we know we want to collect, whether it's because we've applied for a grant and received it and we need to meet some reporting requirements. I didn't mention that we do offer Native Hawaiian healing services as well as Western medicine. So we have templates that I know don't come out of the box when it comes to Lomi Lomi or La'au Lapa'au, all of those traditional Hawaiian services. And so I'm not going to lie, I'm nervous about it, but it's certainly something that we're going to work on to make sure that the progress that we've made, and we have all our own data, so we won't ever lose it that way. It's just making sure that we're able to either have a way to combine that, which with AI and advancement in AI, I mean that's probably not as there's probably less risk now. So great question, thanks for that. And I'm going to say stay tuned.
Great, thank you.
Yeah.
Just while we have you, have a few more questions in the chat. Do they have a process in place to validate the results and data from their AI models, and is there a need to do so?
Oh yes, absolutely. So I think probably one of the things that people talk about is, what is the data that you're using? Does it create any kind of bias? The great thing is, I mean, if you think about the data that we're using, it's all of our patient data, and with over 30 SDOH and other components, and I think so that really is the key, right? I mean, AI is great, and AI analytics, using data, using that to leverage with your data. The key, though, component of that is data, because obviously if you don't have the data, AI can't help you. So I will say that, again, we've been very fortunate having, over 30 years of enabling care service data that's been assigned to every single one of our patients if they've, ever had a service that was offered to them. And then, of course, our 20 years of EHR data. And I'm going to probably say, because I know that it's not easy working with payers and being able, to get your claims data on your patients on a monthly basis, because that's resources on their end, resources on your end. And so, but that really is, you need the data in order for this to do that. And so when you talk about the accuracy of it, our payers that we worked with, I don't have it in this slide presentation, but we did a pilot with them and it's continued. So this was 2 years ago that we did a pilot with 2 of our main Quest providers. And we were able, with showing you what you just saw in predictive as well as prescriptive, we were able to save in total close to $3 million in the risk pool. So very quickly, payers, you have a risk pool for Medicaid where, it stays in there. So in case you have, for your higher risk patients that are going to, whether they're hospitalized or they're going to take more funding will have to go towards their care. Whatever is left over in that risk pool for our patients, we've been able to negotiate where, we half goes back to the payer, half comes back to us. We separate that. So half goes back into these enabling care service operations, and then the other half back into, our general fund. So now being able to save $3 million, now that made the risk pool for each of those that much bigger. And so those payers, remember I told you, they also have their own risk stratification that they do, right? Risk level identification. So they got their actuaries to look at what our outcome was in terms of assigning the risk and how much value it saved. And we were within the 6%, I think it is. So within the percentage that was acceptable in saying, okay, their data is accurate. So we were able to then continue that negotiation. So really the grand bargain in all of that is, let us use this model, right? And at the end, whatever is left in that risk pool, right, it should be higher based on our accurate interventions, impactability identification, and then we have that, what's left over. So I hope that answered the question. Okay, so I'm going to move on because I am checking on the time too. So when we talk about AI and how we're using it in other ways besides advanced analytics, we're using it in our school-based healthcare clinics. Which I had mentioned in our earlier slide, we have quite a few. So all along our coast in our intermediate and high schools. And because of, if anyone has a school-based healthcare clinic, it's all going to be on a walk-in basis. So really having a provider, a mid-level is really, who manages those, our nurse practitioners, having them physically in each of those schools, that really isn't efficient from a provider standpoint. And so our nurse practitioners, they're located in whatever clinic that they're seeing their regular panel of patients. We have MAs that are assigned to each of those clinic sites that then use Title Care. For those that are not familiar, it allows the provider it's a provider use tool. They're not actually using it. The tool is in the school-based healthcare clinic, but to conduct a remote physical exam. Why I'm highlighting this is Title Care just released probably about 6 months ago an AI algorithm that they use for respiratory checks. And so what it does is it detects wheeze. So that device that you see there, the MA, as they're putting it onto the patient who is sitting there with them in the school-based clinic, the provider is then logged in to the provider app and can listen and hear breath sounds, it can hear heartbeat, it takes blood pressure, it can hear abdominal sounds. So when we talk about a remote exam, that's what we're talking about. This tool allows for that. And so as the clinician listens to the breath sounds, the AI algorithm analyzes those lung sounds to then not only detect wheezing, but then it can also detect the level of wheeze. And then if it does detect, it gives like a moderate, medium, I don't know the exact terminology, I can't recall, but it'll then show the provider, right, giving them some clinical decision support. So it certainly doesn't give a diagnosis, but it does offer a way for a provider then to have even more of an enhanced type of exam and providing a little bit more diagnostic accuracy. So thinking about, the amount of respiratory diagnosis, and which is about 40% of patients in terms of what Title Care has in their studies, it really does help to demonstrate how AI can help to improve the care for those common conditions, right? Whether it's asthma, whether it's, RSV, influenza. And so it's been very helpful for our providers in having this additional enhanced type of diagnostic tool. The other thing that we're using in terms of AI is ambient technology, ambient voice technology. Specifically, we're using Nuance's product, which is called Dragon Ambient Experience. And this we rolled out about a little over 6 months ago. And so when I talk about the impact, right, on patient care, that's huge because now your provider and patient can actually look at each other, right? Your provider doesn't have to go to the computer. They're not typing in the notes or typing in as the patient is reporting what they're coming in for and their symptoms. You can have, again, what used to be that provider patient eye contact, because you have this AI, this recording, right, that's sitting there, and there's AI technology behind it, listening to your conversation with your patient. It's able to pick out what is pertinent to that patient's visit and leave out everything else that's maybe just what we call talk story, right? Heard your daughter got married last month. Oh yeah, it was really great. Okay, so now you're coming in for a cold, right? So the whole thing about daughter getting married, that's not going to be part of that note. And so the AI not only analyzes what is being discussed in context, but it also then can put it into a SOAP note, so a formatted SOAP note. What you'll see here, which is just new, when we first signed our contract, part of that AI learning loop was an actual human in the loop. So they would have had a quality person in the background because they were still having the AI learn and improve, right? But once we rolled out, that human in the loop was removed, and that's how advanced the AI is. So in terms of accuracy, there are no humans in the background that are doing any kind of quality check. I will show you how that works because I think, and it's just very quick, just 1 minute. And then Melia, let me know, make
Let's
sure
walk
people
through
can
how
hear.
DEX Copilot works. I'm about to go into the exam room to do an annual physical. After explaining DEX Copilot to my patient and gaining consent based on my organization's policy, I'll set my device down so DEX Copilot's ambient technology can capture our conversation.
Sounds like you've been feeling a bit under the weather. What's been going on?
Yeah, I've been having a rough time this last week. It started out just as cold symptoms.
While I'm in the exam room, I'm 100% focused on the patient, speaking naturally as we go through the visit. DEX Copilot listens, creates a clinical summary, and frees me up to spend time with my patient. DEX Copilot uses conversational, ambient, and generative AI technology to automatically create a clinical summary. So immediately after I'm done with the patient, I can look at the summary, and I have the option to do some editing right in the DEX Copilot app. I can either move on to my next appointment or go to Dragon Medical One on my workstation to add details for this patient encounter. Let's go to Dragon Medical One. When I open the Dragon Bar menu, there's an indicator to tell me I've got a DEX Copilot note to review. I can open DEX Copilot from the menu or say a command. Open DEX Copilot. My clinical summaries are listed on a work list in the DEX Copilot window. Once I choose a summary to work on, I can review and manually edit the note, dictate with Dragon Medical One, or even use commands to get it finalized. While the Summary tab shows the content generated by DEX Copilot, the Transcript tab is a transcript of my conversation with the patient. I can use this to make sure I've documented the full patient story. And now I'm ready to move my document to the EHR to complete this patient's encounter. I can select sections to transfer or copy the entire document. I'll place my cursor where I want the text to go in the EHR and say Transfer Selected to paste the selected sections from DEX Copilot. Any final changes can be made with Dragon Medical One right in the EHR before signing the document. That's it. Now I'm ready for my next patient. Thanks for watching.
So very cool. I think, in terms of the impact on providers, that's, I'm going to say, probably easy to see. It allows providers to really focus on their patient. It takes away really a lot of that administrative burden, right? In terms of documentation. DAX or Nuance likes to call it the pajama time, right? So all the amount of time that our providers are spending outside of their actual working hours to complete their documentation. We've really found, number one, for our providers, very easy to get started, especially for those that are already using Dragon technology. But I also found that we can't assume that all of our providers feel comfortable with technology. And so that's where we need to make sure that we're not only focusing on tech equity and tech digital inclusion, right? The digital literacy part of digital inclusion and just our patients and our community, but really for our providers, and especially for our older providers, who have gone through school, maybe at this point, using an EHR, but where AI is such a new and fast moving technology that it may feel like initially that because it's something new to learn, I don't know if I want to do it. It feels much harder. I'm just going to keep on typing. But, having someone that can train them and be by their side until they feel comfortable using it, then that's when they really find the benefit.
Hi, Chrissy. I just want to pop in
Yeah.
with
Mhm.
two related questions, actually.
Mhm.
Can you share a little bit more about how DAX Copilot works with, with Pigeon or maybe just like local accents in general? How good is it at capturing that?
It's actually surprisingly very good. Maybe not so surprisingly if you think about so Nuance is owned by Microsoft now. So what happens is the recordings that happen, all the patient information is stripped. And then that recording then goes all into a big Nuance database so that it learns not only languages within your community, but that machine learning happens globally. Because if Nuance is used, Dragon and DAX is used worldwide, not just in the US. So in terms of being able to pick up either local words like pidgin or accents, it's very good. And you know what I've got to experience, because I rolled this out with our providers. And if you think about how long I've been with the center, I was in a room with a husband and wife, our CMO, who was the first one to roll it out, and then me. I was actually there with the patient, right? So, and he asked, can we go ahead and use this? They were super excited. The appointment was for the husband. Now, just so happened, when I was in MA, I knew these folks. So I've known them for a long time, but I hadn't seen them for a while. So while the provider was seeing the patient, the husband, the wife was talking to me about, oh my gosh, Chrissy, I haven't seen you for so long. What you doing? How many kids? And I'm thinking, oh no, okay, no, wait, this might be great. I really want to see how DAX can distinguish, right, who the provider is, who the patient is, and that pertinent information. I was shocked, my provider was shocked. We went in, we looked at the transcript, and it said, provider, patient, because it can distinguish those two in the introduction. And then it said speaker 3, speaker 4. Well, once it got translated into the SOAP note, it was just provider, patient, everything pertinent history, nothing, no talk story with me and the wife. And I will say that there are some, and it learns, right, as it goes along. There are some pidgin words, like, yeah, I think one of them was, I'm going to say pidgin, but a lot of times, at least in our community, you'll hear patients say, oh yeah, I had the diabetes, or I had the high blood pressure. So not I have, but they'll say I have the. And so the way that translated in terms of context was a little bit not as precise. And so there is a mechanism in there that you can go in and do a check mark and say, this was inaccurate and this is what it should say. And then it'll learn from there. I think I answered all the questions to that one. Okay, good. So future of AI in healthcare. So when we think about emerging trends, everything from, besides the two things that we looked about, there are also, going to be cameras, which I've actually experienced with our current vendor that they were looking at, where just using a specific camera that has AI algorithm can go ahead and determine based on, skin color and, different changes in tone or subtle vital signs, breathing, can maybe determine or detect issues with heart problems from a distance. So talking about how that's going to even enhance further remote patient monitoring, right? So not just only capturing diagnostic values like blood pressures or pulse ox, but really how if the AI can look at and know have a baseline, what the patient is experiencing or what they may experience even before they realize that they're experiencing, some medical condition. And at the same time, we also want to make sure, and well, again, getting it smarter and smarter. If anyone's following AI and how quickly it's advancing, that's just a given. If anyone's using ChatGPT or Gemini or any of those, you do know, right? We all are contributing to how smart this AI is getting. And so, I always remind people of that. But I think really what should stand out, if out of anything else, is really making sure that we are looking at equity. And that can be at the organization level, right? So I don't know what the future holds in terms of regulating AI and who's going to be able to use it and what that looks like. But if you have smaller provider offices or even community health centers, we're always looking for ways, or always being financially cognizant, right? Fiscally cognizant. And so if those regulations end up being to a point where we're not able to comply because it's not something that we can afford, then that's where now community health centers and the patients that we provide service to, right, are already marginalized communities, socioeconomic disadvantaged populations. They will be most affected. And then, of course, from the patient community side, which I think I hope I've emphasized enough through my conversation, making sure that everyone can benefit from technology and especially AI. Now, in terms of and staff, our staff, so make sure I'm actually looking for this year to make sure that our staff know what kind of AI advances are, make sure that they're trained up, not just our school-based healthcare folks, not just the folks that are using DAX, but everybody, so that they're prepared for what's coming down the pipeline. And then sustainability, how do we make sure, and this touches upon that too, right? How do we make sure that if our staff's jobs are going to be impacted through these AI efficiencies, what does that look like in terms of making sure that they're either trained for different skills to use AI, or just even trained to do a whole new position? I mean, so those are going to be the kinds of things that we need to start thinking about now, not something that's already going to happen in the future. So we want to make sure that it's equitable and sustainable. And then just really at the ending, my call to action, what is it that I hope we all can really get behind and commit to? And that really is to make sure that everyone in our organization, all of our patients, and everyone in your community can really benefit from technology, AI in particular. We have to make sure that everyone can have access to high-speed, affordable interconnectivity, make sure they have the devices that can get connected and they know how to use them, and then and use them in a meaningful way, so that whatever goal or opportunity they're looking to obtain, that they have the devices and skills that they the means that they need to get that done. And then, of course, as organizations, we need to make sure that we have that in place, make that part of our technology plan, right? So part of our strategic plan when it comes to innovation and technology, looking and making sure that our workforce, that they're ready, and then look at our community as well. Because we talk about, at least from a community health standpoint, we provide individual medical care, but really our mission and our vision is to support a healthier community, which then will contribute back to individual health. And at the end, I'm hoping, I probably didn't emphasize this enough, but you can't do this alone. You really need to look and start to foster partnerships. And this can be through, and if you're a nonprofit, don't be afraid of looking at, for-profit companies. There are a lot of AI companies out there that are coming up. I would say, screen them off. If you have any questions, let me know. But you want to choose, like any partnership, right? It starts with trust. You want to choose a business or an organization that has the same mission and vision in mind. The company that we selected, really their mission is to help marginalized communities and make sure that they have the same types of opportunities in terms of realizing better health, better economic stability, the same kind of mission that we're looking at. So that's all part of that partnership. And then making sure that you're looking at what's going to make your community healthier as well. So mahalo everyone for your time. I really hope that I provided some information or something that you can walk away thinking about, and maybe even implement at your organization or your community. This is my contact info. Please feel free to call or email me. I love to share what we've been doing. I love to hear what others are doing, because at the end of the day, whatever health organization you're with, what you do, really the people that we serve are all the same, right? We want to have our patients, whether you're in direct patient care or not, our patients in our community, we want everyone to be healthier and enjoy the life that they have and the family that they have. So mahalo again.
Thank you, Chrissy, and thank you, everyone. So now we still have some time left in our session, so you really want to keep this time open for Q&A if anyone has any more questions for Chrissy. I know that there were a few questions that we missed earlier. So I would like to start with those.
Mhm.
Chrissy, how did you develop the formulas to connect the interventions to annual cost savings? Was that AI generated or was it from another source?
That's going to be through your discussion with whatever AI provider company that you work with, right? So they should have the skill and the background. So the Foresight, and you can look them up, they're Foresight, FORESIGHT, Health Solutions. You can see who their board is, their executive leadership. So the person who founded or created the company, he's a pediatrician by trade. And so he has definitely healthcare background, computer scientist. And so it's going to be a partnership, right? So because it depends on what data you've collected, what community, what challenges, medical, socioeconomic challenges your community has faced, and really what your goal is and how you want to show, right? So if you haven't been collecting any way or been collecting data, so systematically you don't have a way to link up how those social services or those enabling care services have impacted your patient's care, then the AI won't help you. There's no way to do that. I will say, however, if you have not done that, but if you, and I've actually, we've talked about this in the past with other smaller Native Hawaiian health centers that haven't collected as much data as we have. But if you have the same, and this is just something to think about, if you have the same type of patient population or very similar, you could take data, right, as a example, and then fit that into a almost, a pretty good representation with your own patient population that you see and use that kind of as a starting point.
Wow, yeah, thank you. That was really
Mhm.
insightful. These next set of questions are all about DAX. I feel like it
I,
really intrigued this group.
oh, good. Before we get into that, one more thought popped in my head because I was just with I went to two of our Native Hawaiian health centers uses Athena, and they're very small CHCs. I think their unique patient population is just a little over 2,000, right? So if you think about data analytics and you want to have a good amount of number of patients, right? So because their patient populations just individually are so small, Athena had their data analytics folks who were very interested in what we're doing as well on the AI analytics part had suggested, what if they combined their data, right? Because their patient population very similar, but if you combined and then do some analytics around that, and maybe you can come up with some kind of story or result that could help both in terms of negotiating with payers, or just presenting really truly their unique and challenging the things that they're having to address in terms of challenges. So that's just another thought for if there's any smaller organizations on the call.
Yes, thank you for adding that. So we had a few questions related to DAX. The first question is about the price of DAX. Could you comment on the price of that?
Well, like with any other vendor, I can't comment on the exact price, but what I will say is it is definitely worthwhile if you are interested in knowing more about it and whether or not it's going to be, there's a return on investment for you, because it's going to be determined by how many providers, how many patients you see, what your no-show rate is. Gosh, I can't remember. They have a whole, in fact, it's very easy. And this is a no cost thing, right? Is to meet with DAX. They have a whole ROI calculation. You plug in your numbers, how many patients you see, how many patients a provider sees per day, what is the length of, amount of times for each of those types of visits. And then you can then make a determination on whether or not, and the other thing that sometimes it's hard because it's not that tangible, is if we think about provider shortages, right? And we think about provider burnout, how do you determine, and this may come from a provider satisfaction survey, it may come, from other ways, but I think that's one of the things that we wanted to look at and make sure that we address, because provider shortage, that's an issue for everyone around the nation. That's not, specific to CHCs, but for us, it's even that much harder just because, it's hard for us to really compete with pay.
Yes, thank you for elaborating more on that. I really appreciate that. Could you share a bit more about if DAX is capable of picking up on other languages such as Pacific Island languages or different language dialects, and how it might address sign language if that's possible, or if it's only capable of capturing voices?
Yeah, so just voice technology. I can't recall, forgive me, about the different languages and what they support. So again, that would be something you'd have to reach out to them. Because we have, so if it is used, we have interpreters, right? So it'll pick up the English interpreters because we have Pacific language. I think Micronesian, and I can't recall off the top of my head what the actual, Turkey's is one of them. And so it'll pick up the English interpreter. What was the other one you said? Yeah, so I would have to say, when it comes to, and then for sign language, that's going to be a voice interpreter as well. So it is only voice technology. I will say, I'll add in that they just rolled out a new DAX for nurses. So there's a nurse module. So to be specific, and it can be formatted into, I think, whatever a nurse format would be in terms of documentation. And then the latest is an ER version. And so we may be considering that, but yeah, so they have different modules.
Great.
And again, the AI, in terms of accuracy, it's only getting better.
Yeah, I appreciate you kind of clarifying on that. I think that was a topic. DAX is something that's really kind of got us all really interested here. So
Mhm.
I'm always curious to know more. And we'll link to that in the Mahalo email so people can learn more about it.
Great.
Yeah. This next question, are there any precautions to consider, such as confidentiality, sustainability, or climate change impacts when using AI technology in healthcare settings?
That's an interesting question because I always try to be cognizant of those kinds of things. But I will say I haven't really focused on, or can't think of anything now on environmental, um, you know, uh, and then what was the first one? Environmental.
So there's confidentiality,
Oh,
sustainability,
mhm.
and climate change impacts were the main concern.
Yeah. So confidentiality for sure. So if you can imagine our vetting process with our compliance when I first introduced, DAX as a potential new method for our providers to use for documentation. So unlike if we've used Dragon Medical, just Dragon voice recognition technology for many years, but the difference with that is, and we also use NextGen offers a mobile scribe function, which some of our providers use as well, and that's through their mobile phone that gets recorded, and then there's a live scribe who picks up that audio and then actually documents it in the EMR system. So the big difference between DAX and using Dragon, right? Dragon is just the provider's voice, right? It's recording the provider's voice and then turning that into documentation. Whereas DAX, it is recording an entire visit. And I have to say with a patient and provider interaction. And so that's very different. A lot of our providers, the common questions are, is it can a patient request for it like they would do request of information from their medical record? Is it the recording, how long is it saved? And is it accessible if there was some kind of legal scenario that would come up? And so we had to work with DAX to make sure that part of our agreement with them that those things were not the case. So the recording isn't saved. Like I had mentioned before, all the PHI is stripped off of it. And then what is used is used so that it can learn better based off of your particular practice. So it's not at an individual level, so it's not by provider yet, which I would love. You can choose specialties, so be specific, but it's not going to be like, for example, our CM was Dr. Bali. It's not going to remember how he speaks or how he does things, but it does know how, from an internal medicine or general medicine provider works versus a podiatrist. And so you have those two things. The recording is not saved, so it's not something that's retrievable. And that was something that was important. We did as part of our consent process, your patient should have the ability, right? So informed consent, they should be able to opt out, and not only opt out before you start the recording, but what it says in our consent and our providers also emphasize is that any time during the visit, say for some reason it starts to go down a path where the information or discussion becomes really sensitive, and that wasn't something that anyone was really thinking was going to happen, can stop the recording and delete it at that point. So, and that's up, internally, you folks can set up a workflow. And if anyone has questions on how we did that or the consent, feel free to contact me. I'm happy to share.
Thank you. I appreciate you answering that question with a lot of candor. Could you share who helped you with custom templates?
So the way that we have a on-site EMR staff. So our NextGen we host on premise, which means it's not in the cloud. We have servers here, so all of our documentation, our data is here. At one time, now that we're moving over to Epic, my team is smaller, but we had four people, including myself, so 5 on staff. 3 out of the 5 were really assigned to template modification. But what we did was, I mean, it's good because I already had a medical, direct patient background. So that was very helpful. I knew clinical workflow. Another person on my team, she used to be the paper medical record manager. And so she knew that world and how that worked. And then I had a team office manager who she was on the team before I was a director, but we all had this kind of, outside of IT background. So clinical insights, super helpful. But the way that we set it up was we assigned each specialty. So our internal medicine providers, they have a specialty director. Same for our pediatricians, same for our women's health. So their group got together, they designed their template. I had people who either put in a Word document, I had someone bring me a whole big piece of paper with a lot of Post-its and putting into the workflow that they were used to seeing when they wanted to see the information. Example, adult primary care providers, they want to see what referrals were done for that patient at the very top, right next to HPI, not at the bottom. They want to see, did I already refer them for this? Did they get scheduled? Is it already complete? So once they brought that design to us, then our job was to figure out we had to develop it based on NextGen's available features and functions. And so that's really how we developed all of ours. And that's how we work with all of our either departments or programs. Same for our Hawaiian healing. Folks come to us with the ideal workflow, and then we design it that way. So, and then there's no adopting, right? At the end, you don't have to push something on people because they developed it. So you're essentially giving it back to them and then they just train each other.
Great, thank you.
Mm-hmm.
Does your organization have any plans for using AI in clinical decision making? If so, what are the issues you foresee with that?
Well, I think I just mentioned already for title care for the wheeze detection and the level that offers clinical decision support. Now, clinical decision making, I want to say we don't use it, but I know the radiologist folks that we work with, I believe they use AI in some of their diagnostic interpretation, but I want to say that I've not heard of anyone who relies solely on that and doesn't have a human who is then reviewing and then qualifying, that particular interpretation or decision made by an AI. I have not had any conversation where we're going to implement anything that includes clinical decision making by an AI. Again, clinical decision support, that's certainly something that we advocate for and have in using different tools for sure. I could, whether or not that's something, I mean, we have a patient visit summary that I said, I think I mentioned we're using AI to look back at a patient's record. And we also use generative AI to give, especially helpful for new providers or ER providers when a patient walks in, gives a summary of what they found in the patient's record and brings to light what we've worked with the AI, our AI company, and what we deem as pertinent for a patient summary. It's in its early stage, and so we have a little button there that as the provider reads it, it allows them to do a thumbs up, which means if it is a thumbs up, I'm validating that what I see is good. If it's a thumbs down, a pop-up, comes up and says, is there something inaccurate, or is there something that you'd rather see? Was this not helpful? So I know that's kind of a long answer. We haven't had any really discussion about AI decision making as part of our diagnostic
Great.
workflow.
Mhm. So these next questions are a bit related. Are your patients using any AI-powered tools? What is your experience with that, particularly with AI trust? And in similar vein, has a patient ever declined using AI? And what happens if they don't want to be recorded?
So I'll answer the first one. Great question. Again, I think I mentioned earlier, and I wasn't exaggerating, my community when it comes to AI in all of my summits, when I mention it, even just ChatGPT, I encourage people, look it up, it's free, try it out, ask it questions so that you can get an understanding and a feel for when people start talking about AI and AI is here and who's using it and how you're using it. So that's not something that you should be afraid of. It's something that you should want to learn and see how it fits into your lifestyle. I have not met our patients, or any of our community members per se that feel comfortable, or even most of our patients or community members that I've talked to have no idea what chat is, chat GPT. And so, I'll have them go on their phone and just bring it up, or say, there's an app that you can, download, whether or not they're using it, or I have not followed up on any of them. So really it's just, my whole goal is to just keep talking about it so that it's not foreign, and anytime that I can bring it up on their phone or show them or have them read about it, I think that's just, one step forward. In terms of whether or not patients don't want to be recorded, I mean, it's like any other service, whether it's our RPM services, whether it's our telehealth services, we all have informed consents. And so if the patient doesn't want to be recorded, they're just not recorded. And the provider either utilizes, if they're a Dragon provider, they're going to either use Dragon voice dictation, after the visit. They may use NextGen's mobile scribing if they've subscribed to that, or they just may type it in. So, I mean, I think one of the things that we've really committed to as an organization is we know it's not one size fits all for everybody, right? So when it comes to providers and documentation, you're going to have providers who are really proficient at typing, or maybe just don't have, they see their types of visits are just, they're not super complex. It's just a lot easier for them to check off all the boxes in the way their template was designed. Then you have those that have dictated, all their life or feel comfortable doing voice dictation. There's those that aren't. And so we just wanted to make sure that there were always options so that we could really address, provider burnout and removing some of, we call it, the formal word is administrative burden. We call it the humbug factor when it comes to being a provider and having to, address all those things besides seeing your patient.
Great, thank you for your really thoughtful answer. So these next questions are also related. With AI technologies such as DAX or Dragon that you mentioned, have you seen that the use of them has increased the satisfaction scores and efficiencies of your providers? Are they able to see more patients? And what are the providers' satisfaction with using these new technologies?
I'm glad that you asked that. I'll be honest, we have not, at least not that I'm aware of, I haven't done a provider satisfaction in terms of EMR in a while. And so since we just rolled out DAX, I know that we have that coming up very soon in terms of, finding out whether or not this is helpful. When it comes to being able to see more patients, I will say that we never rolled out Dragon or DAX with the message that it would increase the number of patients you see a day. We wanted to always focus on, we want to make sure that we provide tools so that you as a physician, you as a nurse practitioner, that you have the tools that will help to make your work-life balance better, and that we are aware that you see very complex patients. And so trying to make that part of your job that much easier, that's really what our focus is. So whether or not it's help with increasing productivity, that's increasing patient visits per day. That's a hard one too, because what we've been challenged with and what we're trying to hopefully, what I'm hoping to address moving forward with telehealth as another line of service is our no-show rate. And I don't know if what the national benchmark is. I think at community health centers, different, it's around somewhere around 30% no-show rate. That's kind of where we are typically at 25 to 30% no-show rate. So, I mean, there are different things that we've implemented, but I know that was kind of a long answer to the question, but Holly, I wanted to say that we didn't want to focus on telling providers you'll be able to see more patients, because I think there was already, especially coming out of COVID, there's already a feeling of burnout and feeling of doing so much that we didn't want providers to feel like we're asking more of them. We're trying to give you tools to help you see patients in a way that will keep you, can I say, will keep you here at the center? Because we know we don't have the easiest patients. But yeah.
Great, thank you.
Mm.
So here's another question from the chat. I'd love to hear ways that AI can impact jobs. I can think of the downside. I imagine there are upsides for all of us as well.
Yeah, I think of that all the time, and I like to equate it to the internet. I mean, I don't know, I'm old enough. When I was in it, we didn't have internet. And then when internet was being introduced, it was one of those, things where there are people who are excited and people are like, oh my gosh, now there's this, there's going to be opportunity to access all these bad things that, weren't. So like anything else, especially, disruptive technology, there's going to be the good, the pros and the cons, and it's how you use it. So what I would say is that, and I was just talking to so we have a Kapuna Council, Kapuna being in Native Hawaiian is elders. So we have a Kapuna Council through our Native Hawaiian Healing Center. And I was just talking to her name is Auntie Nalani. I was just talking to her yesterday, and we were talking about AI and its impact on, workforce. And I said, Auntie, I've traveled a lot this year, and I can go to the airport. I go to, you go to these airline lounges, and you don't see folks, in terms of service, you don't see folks with brooms and dustpans. They're all robots, going around. And then, you go to a restaurant, and the person that used to walk from the front to the back to get the takeout order for the Uber Eats, it's a robot now. I was in Philadelphia, and they go in, and then some of the Uber Eats punches a code, and the robots, opu or stomach opens with the tray, and they take the food. So, what we need to do as leaders in our organization, leaders in our community, is to help bring this information, bring this technology, bring this education to our community, and then make sure that we learn it, understand it, and then that way we can adopt and implement and innovate when it comes to AI that's most useful for our community, and we make the decisions on how it's going to be used, and how our community uses it and how it impacts us. And so I know it's not going to be as easy as that. I mean, just thinking about again how quickly I was just telling Milia and Maka, I was telling you, I was listening to a podcast the other day, and it was no humans. It was a podcast literally with ChatGPT, Gemini, Grok, and another one, I can't remember the name, but it was four, and they all had names, Claude, someone else, but talking about how AI is going to impact our life. And so that's wild if you think about it. So, that it's an all AI podcast talking about us and how they're going to impact us. So, We
Yes.
just got to stick together and build this future, right? Together as a community, health organization community, as well as, you know, our individual communities, people we serve.
Yes, thank you so much. So it
Mhm.
is 1:29, so I'd like to honor everybody's time. But first of all, I would appreciate everyone's comments they left about the energy consumption concerns about AI. I feel like that's really important, and I'm glad that our folks in our audience are addressing this as well. We hope to, you know, learn more about this as well. Want to extend a big mahalo to Chrissy for being our trainer today. A few reminders to those who are on the call. This training was recorded and it will be uploaded on the Public Health Training Hui YouTube channel after sometime later today. You can find all of our previous training sessions there on our YouTube channel. To receive continuing education credit for today's webinar, please complete the evaluation form that will be emailed to you. I will be emailing people later today within the hour, I hope. The evaluation must be completed by the end of the business day on December 13th, so that's next week, Friday. After you complete your evaluation, certificates will be emailed to you by the end of the year. My goal is December 31st. It is kind of a busy time of year, but if you don't hear from me and it's January, you can shoot me an email at melia@hiphi.org, melia@hiphi.org. It will be the email address you receive your Mahalo email today. Thank you again, everyone again. We hope you can join us for another training session sometime in 2025. Aloha and take care.
Aloha, mahalo everyone.